Good morning everyone, hope you're doing really well. Today our group including Daniel Knox, Sarah Thompson, Violet Kassar and myself, Becca O'Brien, will be taking you through our comparative review of two randomised controlled trials which involved analysing the evidence behind the modified Valsalva manoeuvre versus the standard Valsalva manoeuvre for reversion of supraventricular tachycardia. I'll now pass it over to Sarah who will discuss SVT and the modified and standard Valsalva manoeuvre in more depth.
Thanks, Beck. What is paroxysmal supraventricular tachycardia? PSVT is a type of heart arrhythmia characterized by intermittent episodes of rapid onset and abrupt termination. It is relatively uncommon, occurring in only 35 people per 100,000, however is still one of the more common heart arrhythmias. In most people, the atrioventricular node has a single conducting pathway in which it travels down through the bundle of His, causing depolarization. However, people who experience PSVT have a second conducting pathway which triggers premature atrial complexes. This causes a rapid or tachycardic heart rate, which is commonly asymptomatic, however can cause chest pain, dizziness and shortness of breath. It is commonly seen in women and can additionally be triggered by caffeine and alcohol consumption. The pre-hospital protocol for this condition is outlined in the Ambulance Victoria Guideline Tachycardia Narrow Complex. The first line of treatment for this condition, as indicated by this guideline, is to perform either the standard or modified Valsalva manoeuvre. This presentation is going to compare these two different techniques using two randomised controlled trials to evidently show why the standard Valsalva manoeuvre should be removed from the guideline, leaving only the modified Valsalva manoeuvre as the first line of treatment. So now we're going to take a quick look at what the Valsalva manoeuvre actually is. Vagal manoeuvres are techniques which can decrease the heart rate during an episode of PSVT by stimulating the vagus nerve and decreasing the conduction of electrical impulses in the heart. They are preferred as a first line of treatment for PSVT in the pre-hospital setting due to their non-invasive and low-risk nature. There are several different ways of achieving this vagus stimulation, however one of the most common techniques is the Valsalva manoeuvre. Traditionally, this is where a patient lies semi-recumbent and expires forcefully into a 10 ml syringe for 15 seconds, aiming to move the plunger. This action generates an intrathoracic pressure of 40 millimeters of mercury, which has been suggested to be the optimum Valsalva manoeuvre performance pressure. After 15 seconds, the patient is then left in the semi-recumbent position for 45 seconds, and this process can be repeated up to 3 times, aiming to terminate the arrhythmia and return the heart to normal sinus rhythm. This technique can be seen in the image on the screen, labelled the standard Valsalva manoeuvre. The recent studies have identified, however, that a slight postural change can increase the rates of reversion and thus effectiveness of the manoeuvre. This change involves laying the patient supine with their legs elevated, following the same 15 seconds of forcefully expiring into a syringe, and this is known as the modified Valsalva manoeuvre. This can also be seen in the image above, labelled modified. Now passing over to Dan, he's going to take us through the evidence which we found, as well as the search criteria.
Thanks, Sarah. I will now be talking about evidence identified and search criteria. Our comparative review identified two randomised controlled trials, the first being postural modification to the standard Valsalva manoeuvre for emergency treatment of supraventricular tachycardia. We've named this RCT1. The second being comparing the success rates of standard and modified Valsalva manoeuvre to terminate PSVT. We've named this RCT2. As you can see in the table, both randomised controlled trials had a confidence interval of 95%. The p-value of randomised controlled trial 1 is less than 0.0001 and the p-value of randomised controlled trial 2 being less than 0.05. The p-value indicates statistical significance with a smaller p-value demonstrating stronger evidence against the null hypothesis. Therefore, given that randomised controlled trial 1 has a smaller p-value, the result is considered more significant. Randomised controlled trial 1 also utilised a parallel group trial across 11 emergency departments, giving it a wider range of patients and providing it with more accurate data in cardioversion of SVT through both of the Valsalva manoeuvres. This means that the evidence and data collected in both of the randomized control trials is quite strong, allowing us to utilize the data and evidence for our own analysis into both of the standard and modified Valsalva manoeuvre. I'll now hand you over to Beck, who's going to talk about analysis of the evidence. Thank you.
Thanks, Dan. To analyse the evidence of the research, we looked at the similarities and differences between each of the studies and identified whether or not they had an impact on the quality of the results. RCT1 has greater reliability as the sample size was much more significant, being 433 compared to 56 in RCT2, and the study was performed over a much greater period of time, being 27 months compared to 12 months in RCT2. Both studies avoided the risk of allocation or selection bias through using randomization, and this study design also enabled the two different Valsalva manoeuvres to be directly compared to each other. RCT2's results were deemed as inadequate to be generalized to all patients with PSVT. Neither of the studies were able to make use of patient blinding due to the nature of the trial. It wasn't possible. In summary, both studies use a randomized control trial, but RCT1's results were more reliable due to sample size, study time, and the use of technology to monitor patients throughout manoeuvres. Dan will now discuss the rationale for change.
Thanks, Beck. Now looking at the rationale for change, upon collecting the evidence from both randomized control trial 1 and 2, we can see that the success rates in the termination of supraventricular tachycardia through utilization of the standard Valsalva manoeuvre in randomized control trial 1 was at 17%, compared with 43% in the modified Valsalva manoeuvre, over twice as successful in cardioversion. Randomized control trial 2 identified similar numbers, with success rates being 10.7% through the standard Valsalva manoeuvre and 42.9% in the modified Valsalva manoeuvre, 4 times more successful than the standard. The rationale for change comes as the data shows that the modified Valsalva manoeuvre is more effective of the two. The modified Valsalva manoeuvre is also low risk, it's cost effective, it doesn't require any additional medical equipment as it also utilizes the 10ml syringe and indirectly reduces the need for pharmacological intervention such as adenosine. I will now hand you over to Violet, who will discuss the recommendations of our comparative review. Thank you.
Thanks, Dan.
Historically, in Ambulance Victoria's clinical practice guidelines, supraventricular tachycardia had been treated in a pre-hospital setting by either the standard Valsalva manoeuvre or the modified Valsalva manoeuvre. However, recent research indicates that the modified manoeuvre is far more successful in achieving sinus rhythm in patients and therefore should be adopted as the best possible practice. Given the superiority of the modified technique in treating supraventricular tachycardia, the standard Valsalva manoeuvre should be removed from Ambulance Victoria's clinical practice guidelines. In saying that, there are still limitations that must be considered, such as the way that previous research had been conducted in a contained clinical environment. While the results indicate that the standard Valsalva manoeuvre is inferior to the modified Valsalva manoeuvre, one must be cautious in interpreting and generalizing the results to an on-road environment where the conditions are much different.
Here you can see a list of the references which were utilised throughout our presentation, and following this slide you will see our group contributions. We would like to thank you guys for listening to our presentation on the standard versus the modified Valsalva manoeuvre, and we hope you enjoyed. We would now like to open the floor for any questions that you have.